Hello and welcome, everybody. So for today's HTN discussion, we're chatting with Jeff McDermott. Sorry, Jeff Davis from McDermott Plus, the author of the invaluable newsletter Regs and Eggs, which just came out this morning, and you should subscribe, and an expert on healthcare and regulatory policy. Jeff, do you want to do a quick introduction?
Sure. So I've been in McDermott Plus. Thank you again, Martin, so much for the invitation. I really appreciate it. I'm happy to be here today. I've been in McDermott Plus for about 2.5 years. I've been primarily work on the regulatory side, so diving deep into these regulatory policies. I love my regs and eggs, so write that every Thursday morning and get that out. But work with a lot of clients in the healthcare sector. We're trying to navigate all and everything on the regulatory side, primarily with CMS and all the payment rules and other federal agencies as well. Prior to that, I was at the American College of Emergency Physicians, or ACEP, where I was the Director of Regulatory Affairs, so handled all their interactions with federal agencies. And before that, I was at HHS. So I started my career as a Presidential Management Fellow, which is no longer in existence, unfortunately, but a PMF at the Department of Health and Human Services. I worked in the budget office for about 8 years doing Medicare payment policy.
Well, you're pretty much the perfect person to talk to then about the Medicare Physician Fee Schedule. I think I was thinking a good place to start would be to kind of talk about the place that the Medicare Physician Fee Schedule plays, or the role it plays, and how it interacts with the other fee schedules, prospective payment systems. Like what's covered by Medicare Physician Fee Schedule and what's covered by the other stuff.
Great. So CMS updates payment rates for a lot of different types of providers, and they do so on an annual basis. And it's a little bit confusing the way they do so. Some of those are through a fiscal year basis, so October 1st through September 30th. Those are mainly the facility, hospital payments, inpatient hospital payments, but also they do calendar year rules. And with calendar year rules, those are ESRD, home health, the hospital outpatient prospective payment system, and the PFS, Physician Fee Schedule. Under the Physician Fee Schedule, CMS annually sets the conversion factor, which is what updates payments every year, which turns the RVUs, relative value units, into dollar amounts, and that's updated every year. They also look at codes and other policies and make annual updates. This is a huge fee schedule, so there's always policies, always something of interest in these rules. Now, what's interesting, Martin, is all these rules, the calendar year rules, the final rules were due on November 1st. So they had to be implemented by November 1st, 60 days prior to the start of the next calendar year. That gives, by law, enough time for stakeholders to review the final policies and get themselves ready for the next calendar year. These are major rules, and again, 60 days is what is required by law. Now, the shutdown did impact operations, and interestingly, only one of those rules got out on time, and now it's a Physician Fee Schedule. The other rules, the ESRD rule, the home health rule, ESRD home health, and I'm blanking on the last one.
Outpatient?
Outpatient prospective payment system. Thank you. I was just blanked for a second. Appreciate that, Martin.
No, of course.
Have not been yet been released. We think that outpatient prospective payment system rule may be released next week. But again, all those were due on November 1st, but only the Physician Fee Schedule got out. And there's various, perhaps, rumors about why that got out first. They wanted perhaps to make a splash with a headline with the skin substitute policy in terms of saving the government, I think, $19 billion, they said, in terms of what they believe to be fraud, waste, and abuse with skin substitutes. And there were some, as we discussed, Martin, some controversial policies, primarily that really create huge discrepancies in payments between certain types of providers and have large shifts in payments as well.
Yeah, I think that that's a perfect transition for where I wanted to go next, which is okay. So before we actually get into the controversy, can you give us a high level overview of how the like budget neutrality and the one-time raise and how that the payment factors work?
Yeah, and this is a rule, Martin, where budget neutrality. I'm going to mention budget neutrality a lot because this is the predominant. It plays a predominant role in this rule particularly. So we have two sides of the payment coin here for how doctors and clinicians are paid. You have RVU changes, and then a conversion factor, which takes those RVUs and changes it into a dollar amount. But in this rule, both issues are at play here. And something's called budget neutrality as well, where if you change the RVUs, if you increase or decrease those RVUs, you have to make an overarching adjustment to the conversion factor. That's how CMS does it, so that otherwise there'd be no increases or decreases in spending. In other words, changes to our obviously there's going to be increases in spending every year because Medicare beneficiaries and everything, and growth in utilization of services. But the RVU changes themselves cannot result in a change in spending, according to CMS's estimates. So if they make changes to RVUs, that has to adjust the conversion factor. There's also, and we're getting to this, another budget neutrality component. Budget neutrality, again, is the operative word in this rule for practice expense. Practice expense has its own budget neutrality rules. So if you cut practice expense for one set of services, then you have to redistribute it to other sets of services. So in that respect, budget neutrality plays a key role here. And in this rule, again, the conversion factor is at play and the RVU changes. And in terms of the conversion factor, there are really three aspects of the conversion factor here that, to look at. One is an annual update that's set under the MACRA. MACRA is a big law that passed in 2015, and that provided actual updates, statutory updates for clinicians under the physician fee schedule. And for the first time, starting in 2026, there's actually two updates under MACRA. One for those that are in APMs, qualifying APM participants and advanced APMs, and one for all others. So there are actually two conversion factors because of MACRA. There's a 0.75% update for those in advanced APMs and 0.25% update for all other ones. The second kind of component was the One Big Beautiful Bill Act provided a 2.5% increase in the conversion factor one time for 2026. And then the third factor is this budget neutrality. And because, as I'll talk about in a second, one of the policies actually resulted in a positive budget neutrality update. You get cuts to the RVUs, resulted in a positive budget neutrality update. Again, RVUs go down, you redistribute those cuts to the conversion factor. It resulted in a positive update. So overall, the conversion factor is up for those in QP in advanced APMs around 3.7, 3.8%. For those non-APMs, about 3.3%. So this is the first time, Martin, in 6 years, there's actually a positive update to the conversion factor. Last 5 years, negative update. So clinicians should be excited about this rule, but as we're getting into, some of them are not excited because of, again, conversion factor, great. It's the RVUs that we're talking about here now.
Well, let's get into the RVUs and talk about which types of doctors ended up better off and worse off, and what was the thinking for the administration there on these changes?
Yeah. So the RVU changes, again, there's a lot of codes in the physician fee schedule, and there's something called the Misvalued Codes Initiative, where CMS, traditionally using the AMA RUC process or other processes as well, look at each code individually and look at all the inputs of the codes and make those RVU adjustments every year. This year, they kind of took a hammer instead of a scalpel approach to RVUs through two major policies. And I'm going to talk about one first, the efficiency adjustment, and then I'll get to another one, the indirect practice expense reallocation. Now, it's important to just distinguish the two. The efficiency adjustment deals with the work RVU, and that actually impacts the conversion factor. And as I mentioned earlier, Martin, the other one, indirect practice expense reallocation, it has its own budget neutrality implications because PE, practice expense, redistributes money among the different practice expense units, which impacts, I'll tell you how that kind of affects doctors in a minute. But let's first start with the efficiency adjustment. So the efficiency adjustment is its overall approach that CMS has taken and thought that overall changes to individual codes have not actually been that successful in being updated routinely and take into account efficiencies built into them over time. They talk about in the rule that even after a particular code is revalued, it takes a few years for those revaluations to go into effect. There's issues with surveys and other issues with actually evaluating code by code. But in general, they think that certain non-time-based codes, about non-time-based codes, that means like procedures, imaging studies, certain things that are not like evaluation management, like visit codes, but really procedures, there should be efficiencies built in over time. These codes should be valued, and actually the work it takes to and the time it takes to complete these services should decrease over time. As people get more used to these services, as they deliver them more frequently, that the time it takes to complete them should go down. So in the proposed rule, and we see in the final rule, CMS proposed and then they finalized a overall 2.5% cut to the work RVU and the time-based piece of that. So looking at the work RVU and how much time it takes to complete certain procedures, they cut that by 2.5%. And that impacts a lot of procedures. Now, CMS got a lot of comments on that proposal. The proposal applied to 9,000 services. 9,000 services, 9,000 procedures, which is a lot of different procedures. And they got a lot of comments saying, no, 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 no. As new technology, as people have, as new complexity in providing these procedures, it actually takes sometimes longer for you to actually perform the procedure and do all the analysis in the back end to analyze the results, particularly with some imaging studies and everything that was captured in all of those procedures. A 2.5% cut to all those procedures is not really appropriate in the stakeholders' view because it does not take into account increases in, again, technology and other factors that CMS should really study. CMS thought about those stakeholder comments, but decided to finalize it anyway. They did make one change where they're not applying into new codes, and because of that, the number of codes decreased. They have a spreadsheet that says all the codes that apply the efficiency adjustment. It's only 7,700 codes instead of 9,000 codes. So it decreased by about 1,300 codes because they're not applying it to new codes. So a smart carve out compared to the proposed rule, but not what stakeholders want. A lot of stakeholders wanted them to delay the policy and not finalize it. Now, again, this is where budget neutrality plays in. Because of the cuts to the RVUs, there's a positive update to the conversion factor. In the proposed rule, it was a little higher, about 0.55%. In the final rule, because it applies to less codes, the positive update to the conversion factor is a little lower. It's about 0.49%. But still, because it's a 0.49% positive conversion factor, folks that don't bill these procedures, that 7,700 procedures on the list, benefit from that positive budget neutrality adjustment. While those that do provide those services, they're still benefiting from the positive budget neutrality adjustment, but not as much because their RVUs are getting cut. So you got to look at both sides of the coin there. So you have certain physicians that are happy and certain physicians are not happy, and that's because of budget neutrality.
That was a great way to think about it. And you think about, it's a balloon, and if you squeeze one end, it goes somewhere else. Can you talk about what who are the physicians that have the biggest impacts for this?
Yeah. So the biggest impacts are those that provide a lot of procedures, the surgeons, all those clinicians that really are specialists that, again, that don't do a lot of primary care or office-based visits, don't bill a lot of evaluation management codes, which were excluded from the list. Again, we're really focusing on procedures and imaging services. Those specialists that perform those services are particularly hit. Now, if you look at the data, and it really depends on the what services you perform. So you have, again, overall about 3 or 3.5%, almost 4% increase in the conversion factor. If you are providing services that with that 2.5% cut, and as I explained to you, the indirect practice expense reallocation also cuts RVUs for the practice expense RVUs. If all those RVU changes decreases by more than 3.5% or 3.7%, or then you actually have a negative impact. Sometimes what we've been finding for certain specialties, some of them are getting hit more than that 3.5%, so they're actually seeing a decline in payment. Some of them are getting hit, a little bit, so that they're not seeing the full conversion factor update. And some of them, those clinicians that don't bill any of the procedures, are not impacted by the indirect practice expense reallocation, which I'll describe in a minute. They're actually seeing even a bigger than the 3.3%, a 3.7% increase in their payments this year. So again, I hate to use this term, but I'm going to use it anyway. Clear winners and clear losers in this rule.
This is sort of an example of why it's so hard to save money in healthcare is, you say okay, we want to, it very helpfully, the people who do evaluation management, they tend to be primary care providers. Primary care providers are some of the lowest compensated physicians in the US. The specialists, they usually make more money. And so this is doing a little bit of rebalancing, but people are upset about it because they're losing money.
And they think that, again, not only is it the approach of they're losing money, but just thinking about this long term. I forgot to mention CMS wants to do this every 3 years. So they want to do another efficiency adjustment in 2029, then 2032, etc. How much efficiencies can you get out of one code? That's one question. And also, this is, again, taking more of a hammer rather than a scalpel approach. I think there's a lot of interest in looking at each individual code. I mean, when codes are surveyed under the RUC process, the CPT process, these codes are scrutinized at every single level to see how much time it takes to do a particular service, what in terms of practice expense, how much overhead administration it takes, how many at one point how much gauze is in need for a particular surgery. That's the level of detail they get into specific codes. And here CMS is taking an overall approach and is cutting 2.5% bluntly for the efficiency adjustment. So I'm really looking at really the particulars of each individual code. And that makes it a precedent for other policies going forward where they, again, use a hammer rather than a scalpel.
It does seem to me like there's, some merit to that idea that if you are performing procedures when the procedure is new, it takes you a little bit longer to do it, you're less efficient, and then you get more efficient over time. But to the point, the other point is like, well, what happens when there are improvements and it becomes
Yeah,
actually
and
less
there's
efficient?
yeah. For instance, like if they use new technology that leads to better healthcare outcomes, but it takes longer,
Yeah.
or there's more when you do imaging. Obviously, the imaging has become very, very granular, and you can look and it takes longer to interpret those studies. So this time really, even though there may be efficiencies in the way we did things before, does that really mean that with new technology, advanced capabilities of analyzing the results, is it really taking that much shorter amount of time? But again, we have to look at the healthcare outcomes. I think we have to look at the healthcare outcomes. Even if it takes longer, the better healthcare outcomes, we don't need to necessarily assume these efficiencies. So again, both sides of the coin, you make a very good point, Martin. People, and that's what CMS's point is. If you've been doing this for a long time, it shouldn't take you as long. But there's, I guess, both sides to that equation there as well.
Yeah. Well, let's talk about practice expenses. And so I think, there's direct and indirect practice expenses. It might be helpful for listeners and watchers to break down what falls into those buckets, and then we can talk about how it's changing.
Yeah. So direct practice expense really is for the office-based services where what is your overhead, your administration, what it takes for your practice expense, like to actually deliver that actual service. So like the direct is for that actual service it takes, what kind of supplies, equipment it needs for that actual service. Indirect is everything, general overhead, not for that specific service, but overall arching, like paying staff, administrative support, IT, all the things that it takes to keep the lights on to deliver services in general. So direct is really for that particular service, and indirect is for overarching to maintain a practice. And what CMS is doing here is saying that for the indirect piece, so the overarching overhead, right now, under the way it's done, is that you have services delivered in facilities and non-facilities. Facilities are like hospitals, ambulatory surgical centers. Non-facilities are like the office-based settings. Right now, the way up until January 1st, 2026, I should say, the indirect allocations for practice expense has been the same for those clinicians performing services for the services delivered in facilities and those services delivered in non-facilities. So, but CMS believes that over time, and that was based on the assumption, I should say, Martin, that when you worked in a hospital 20 years ago, there's an expectation that you also own your own independent practice. A lot of folks used to own, doctors have traditionally owned independent practice and then worked in the hospital setting and not necessarily always been employed by the hospital. CMS is arguing that over time that's shifted. And now with consolidation in healthcare, more hospitals are buying up physician practices. That's what CMS argues. And that the overhead, they don't have these physicians don't have to bear these overhead costs, these administrative costs. I should remind you that under the OPPS, there's also another facility payment made for those overhead costs. So the hospital is already getting that money. CMS is arguing that because the hospitals own the physician practices, in their opinion, I'm trying to be very clear, in their opinion, that they don't have to pay twice for that, and they can at least reduce that indirect practice expense for facility-based services. So what happened in this rule is that they made an overarching judgment saying, okay, we're going to reduce indirect practice expenses for facility-based clinicians, for facility-based services, I should say, by half compared to non-facility services. So if you deliver service in facility, your indirect practice expense has been reduced by half compared to those same services delivered in a non-facility setting. So what does that create? And because of that, I should say, because of budget neutrality, because you're cutting the indirects for the facility, all the practice expense that you cut is redistributed to the non-facility setting. So the non-facility setting services are getting huge bumps. So in the rule, this really plays out in the back of the rule. There's a table for data geeks like me. I look at the table, the impact analysis. I was in the budget office. We worked on the impact analysis, and it shows the services and it shows by specialty the breakout of RVU impacts for facility and non-facility. And you will see huge discrepancies, huge cuts for facility, huge increases for non-facility. So physicians that work primarily and provide services primarily in non-facilities, like physician offices, primary care folks providing office visits in non-facility settings, they're going to see a huge increase in payment. Those physicians that provide a lot of services in facilities are going to, even among the same specialty, and are going to receive a decline in payment. And so you see discrepancies even among physicians in the same specialty, depending on where you provide those services. Again, clear winners and clear losers in this policy. The CMS's argument, again, is that there should not be as much overhead costs if you are working primarily in a facility, because the hospital bears some of those costs. But Marty, I think you have to assess what the stakeholders said. Stakeholders who work primarily in facilities obviously opposed the proposal when it was proposed, and said that no, a lot of physicians that work as part of a hospital are not actually employed by hospitals. They actually run independent practices, and that contract with the hospital for those services. And the hospital actually relies on those independent practices for a lot of these overhead costs, for staffing, for other support, for IT in some cases. So the independent practices, even though they work in facilities, actually bear a lot of overhead expenses. And what they argue also is that CMS's argument is that this is because of consolidation. And they say, wait, this is actually going to lead to more consolidation, because these independent practices are going to lose money, who work primarily in facilities are going to have no option but to join up with hospitals. So it could actually do what CMS is arguing that they don't want to happen, and actually lead to more consolidation. So that was their argument. CMS said, thanks, but we take your comments into consideration, but after considering your comments, we're going to finalize as proposed. So in that respect, the efficiency adjustment was a little bit changed, like I said, but this policy was pretty much finalized as proposed. And again, leading to major discrepancies in payment depending on where the service is delivered, with big increases for non-facility, big decreases for facility-based services.
That makes total sense, and you explained that so well. A question that I've had since I've started getting into healthcare finance and policy is, so if I'm like, let's say I'm a surgeon and I do hip replacements at an ASC, I'm getting paid from the physician fee schedule. And
Correct.
that's either and there's two rates in there. There's a facility rate and a non-facility rate.
And you're going to pay the facility rate because you're in the ASC.
Great. Then under the outpatient and ASC rule, there's another facility rate for that hip procedure.
Correct. And the hospital get paid the facility
And the
fee.
hospital gets paid that, or the
Yeah,
ASC owner. And
yes. So the argument, CMS's argument is that why are you paying the same thing? You shouldn't pay overhead twice, obviously. Or if this doctor's providing services in ASC, then you should, and you're also paying facility fee to the ASC. Why are you doing that? But again, the physician's argument is that we're independent. We're not employed by the ASC. We're not employed by the hospital. We have our own expenses we still need to bear. And I will say, what's interesting about this policy, and again, I can't believe I forgot the name of the OPPS. I was talking about OPPS. I've been talking about OPPS so much, but sometimes it's a mind blank. But with the OPPS coming out, they have a lot of site neutral policies in there. And it's going to be very interesting to see how that plays out, because one of their policies is expanding the number of procedures they've performed by an ASC, expanding the ASC procedural list, right? So they want to shift to lower cost sites of care like ASCs. That's what CMS's proposal is under the OPPS. But on the PFS, you're cutting payment for the docs that work in ASCs. So on one side, you're trying to incentivize more care in ASCs. On the OPPS side, on the PFS side, you're saying we're cutting payments for those docs that work in ASCs. So even if you're gonna, try to incentivize more care to be living in ASCs, if providers don't want to work in there because their payments being cut, it's what's something's gonna have to happen there. So I just thought that's interesting that those two policies may not be in alignment there.
It is interesting to think about the interaction there and whether
Yeah,
it's just going to lead to more consolidation.
and that was exactly the argument that made by stakeholders. So obviously you have two sides. The primary care folks are very, very happy. The specialists are very upset. I mean, and again, budget neutrality is what's driving this wedge. Also, these overarching shifts, overarching adjustments. And you already have folks, and this has been reported in the news, going to the Hill as we speak, trying to get with some folks saying, Congress, don't you dare touch these policies. Let them, play out, on January 1st, 2026. And the other side, the specialists going and saying, we don't want these policies, do whatever you can, delay these policies or phase in implementation. There has been precedent in terms of a couple of years ago in 2021, there was an add-on code for complexity G2211 that caused a big budget neutrality adjustment. Congress actually delayed that until 2024. So there has been some precedent towards Congress intervening on a policy and at least delaying implementation. Now, Congress just reopened the government. And I think
they've got some other stuff on their
they
plate.
got other stuff on their plate. I'm not sure where this lies, but I do know, Martin, that folks are on both sides are already making their voices heard on the Hill.
I would be surprised if they weren't. But yeah, this is like again, like we were talking about before, it's very hard to save money in healthcare.
Yeah, especially I mean, with the budget neutrality. Now, there are other ways you can. There are other policies in the fee schedule, and one of them that they're touting is the skin substitute policy, which actually does CMS.
Yeah, let's talk about the skin substitute policy. I feel
$19 billion.
like
Yeah,
skin substitutes
yeah.
very much a topic
Yeah,
of
it's
conversation around them.
so they changed the methodology for payment from ASP plus 6% percent being incident to, and in that respect, they believe they're going to significantly save money, and you've already seen stakeholder reactions to that, particularly around the ACO community, actually, where ACOs, because these costs have been included in their benchmarks, included in their spending, it's been hard to meet those benchmarks, and they've argued that there's been a lot of fraud, waste, and abuse, and that's what CMS is arguing here, in that space, and therefore by reducing, by changing the methodology and pretty much cutting payments, that would be actually more. That really gets on this fraud, waste, and abuse angle of it, and that's what CMS is arguing, what ACOs are arguing. Again, there's always two sides to every story, but at least that's the one that CMS is trying to tout here. Now, what's interesting about this, and they talk about this a little bit in the rule, even though they think they're going to save $19 billion, in this from this policy, it's not because it's going from ASP plus 6 to an RVU based Institute methodology. They have no data on which to base the budget neutrality calculation, so it's not actually included in budget neutrality this year. But they think once they get the data utilization, that it could be included in budget neutrality in future years, and perhaps even cause a decline in the conversion factor. So we have to watch out for that going forward, about how this policy will impact the conversion factor because of budget neutrality going forward. So that's what I'm watching out for. I'm not an expert on the skin substitutes themselves, but in terms of the fee schedule, it'll be interesting to see how it plays out going forward.
Super interesting. I don't know. Are you an inside health policy reader?
I am, yes.
So the advertisement this morning when I logged in was, "Dear Congress, Medicare's planned cuts to wound care coverage will endanger billions of Americans."
Yeah, I mean, there's both sides in every issue, and you're right, Martin. I mean, both sides in every issue, and you definitely and I think again, I'm going to say this 1,000 times, but I think it's worth repeating 1,000 times. The fee schedule creates clear winners and losers because of budget neutrality, and it pits folks against each other. When I think, in my opinion, we should be working collectively for the common good of improving healthcare for individuals. That's my opinion.
Yeah.
But with the fee schedule, because of budget neutrality, you have clinicians pit against and other stakeholders pitted against each other, and that's just to me an unfortunate kind of scenario here.
Jeff, there's so much more we could talk about, and so we're gonna have to have you back again soon. But
telehealth. There's so many other policies in the rule.
I
Uh,
feel like the telehealth journey that we've all been
I
on
mean,
over the
I mean,
last.
which is interesting because the Congress obviously weighed in on the telehealth issue of the originating site and geographic restrictions, but CMS also made some major moves in this year's rule. One I just talked about very
Yeah,
quickly,
yeah,
Mark,
yeah.
it's really important, is the fact that they have maintained two lists of what services can be covered under Medicare and provided via telehealth. So not looking at geographic and originating site restrictions, but what services in general can be paid for under Medicare. And they have this list of over 100 codes. A lot of them were temporarily added during COVID-19. And in order to get them permanently on the list, you had to go through what I believe to be a big process of providing actual data, a lot of studies, and really a really high bar of getting them from the temporary list to the permanent list. Almost, I would say, an impossible bar. What CMS did now is they're saying, okay, we're going to simplify things as long as they can meet the criteria for being able to provide via telehealth services. They meet other coverage criteria under Medicare and can be paid under Medicare and we're moving all the codes from the temporary list onto the permanent list and getting rid of the temporary list, which stakeholders supported and CMS finalized. So now you have all these codes that were temporarily on the list, and folks were saying, oh, are they going to be kicked off? Or are they going to be added permanently? Now they can rest assured that all of them are permanently added to the list. And then CMS also did some stuff on flexibility of supervision, which again, they're really seem to be pro telehealth and doing more things to expand the use of telehealth.
That seems like a no winners or losers. We're all winners
Yeah,
on
yeah,
the
yeah, yeah.
telehealth
So
front.
yeah, yeah. So a good place to end. This is great. Yeah.
Yeah, look at that. Well, Jeff, we're gonna have you back soon. But in the meantime, where can people find you if they want to get in touch?
So McDermottplus.com, or you can Google Jeff Davis, Regs and Eggs.
You gotta subscribe to Regs and Eggs.
If you want to subscribe to Regs and Eggs, that would be great. It's free. Anybody can read it. Send it to your friends. I really try to keep the public updated on what's going on because regulations are important and and interesting. We just had a great
Yeah,
conversation. So yes,
we could have talked for like
we're
another
going to talk
hour.
for the yeah,
It was a
exactly.
2,300 page rule, so we could have
Exactly,
talked for
exactly.
probably
And we're only talking
many
about
more
like
hours.
two issues or three issues in the whole rule. Again, 2,300 pages in the regulations. So yeah, but
Yeah,
not everyone loves the regulations as much as I do. But that's just the way I am.
that's a shame, I think.
Yeah.
Well,
But
thank you
thanks,
so
Martin.
much for your time today, Jeff. We really appreciate it, and we're already looking forward to having you back.
Great. Well, thanks so much, Martin. Take care,
Thanks, Jeff.
everybody.
Bye.